Thank you very much. And thank you to Miach for hosting this. And thank you everybody for taking time out of your evenings to join us. So when we talk about the BEAR is designed to restore the native ACL. It's one of the very first options to be able to basically replace the ACL by allowing it to create its own barrier from the synovial fluid. And then that will be replaced by native cells, collagen, and blood vessels. So it really is an opportunity for us to restore ACL throughout the entirety of the whole ligament, not just talking about type 1 tears. So let's go back to the basics of the problem. Why don't ACLs heal? So we all have taken care of athletes with MCL injuries, and by the most part, we don't need to operate on MCL injuries. And why is that? It's because a clot or bridge can be found seeing at that wound, and as long as we stabilize that with a brace and allow the patient to heal that on its own, that MCL will heal in a very stable knee and a very functional MCL for the lifelong of the knee. But we don't see that with the ACL. With isolated ACLs, non-operative treatment tends to result in a clinically unstable knee for the life of that knee, resulting in further injuries, resulting in cartilage, meniscal, and then cartilage injuries. And so the reason why the ACL doesn't heal is that the synovial fluid creates endothelialization of the ligament, and we can't get that bridge formation that we see in the MCL. And so while we see good cell migration, we don't get that bridge that we need at the wound, particularly when you're looking at type 2s and type 3s. And so while ACL reconstruction has been very successful, it's not perfect. And clearly there's not one preferred graft because there are so many options that we still haven't decided on what's the best. We have BTB autograft, which has been considered the gold standard. We have hamstring autograft that's preferred for patients who may want less pain, postoperative pain. The quadriceps autograft has become very popular now and attempts to reduce some of the comorbidities associated with BTB and hamstring autografts. And then allograft, which has been typically used in older patients afraid of the associated comorbidity of pain, but of significantly higher failure rates compared to all the other autographs. And so we also didn't even talk about the prevalence of post-traumatic osteoarthritis, which is a significant finding in patients with ACL. And we found that in the early bear studies, we had in the animal studies, we had decreased rates of post-traumatic osteoarthritis. It's a very shallow learning curve performing ACL. Whereas if you can do an ACL, BEAR is fairly easy. And when you take a graft, you're limited, right? So you can't take another BTB graft. You can't take another hamstring autograft. You can't take another quadriceps. You have to take another graft, and we're further compromising the knee. So why is the AIR implant different? Because instead of replacing, we've done that for a long time, we have repair, which has typically been used for type 1 types tears. But BEAR truly allows us to restore the native ACL across all tear types by creating a bridge that is gap with blood, and then the hydrogel creates around the area of healing and allows the ACL to heal on its own. So when you're looking at the BEAR implant, this is really what changed the algorithm and the options of repair, is that we were really fairly limited repair in the proximal type 1 tears. But now we can apply repair techniques and repair options to our patients in the mid-substance and even some of the distal. You just need to have enough tissue to be able to put a suture through the remaining remnant to align it within its native fibers. And this doesn't require us to change anything, learn something new, do different. We're just using the same anatomic principles of ACL in terms of where our drill holes are going on the femur and on the tibia. We're remaining all of that implant, all of the remaining fibers of the ACL are stayed in place. We're drilling 4.5 millimeter tunnels rather than 8, 9, 10 millimeter tunnels. So we save plenty of bone if we ever have to go back and do an ACL reconstruction. And you can continue to perform it the same way you perform ACL reconstruction. We're just using the BEAR implant to take the place of the empty space of the ACL, and no bridges burned. So when we talk about what we're trying to do here, on step one, we have this biologic healing. So we're able to take autologous whole blood. We're not using any allograft tissue or in any nature. The allograft is filling the area of the BEAR implant. It becomes fairly mobile at that point. If anyone's done a BEAR, you know the original implant is fairly stiff. Once it becomes hydrated with the blood, you can easily place that in within the knee through a very small arthrotomy. And within 8 weeks, that BEAR implant is gone. It's replaced with the patient's native cells. We are able to achieve an anatomic fixation by putting sutures through the remnant and then directing them to the anatomic footprint. And then by performing putting a suture, we can reduce the tibia and reduce the subluxation of the tibia on the femur to allow for an appropriately tensioned ACL healing. So again, the BEAR is critical because we preserve the anatomic orientation in the joint. We also preserve the native ligament biology and proprioception, all the nerves and blood vessels staying there, and it eliminates the need for a graft and intraoperative complications. And again, no bridges burned. So like I said, this has been studied for a long time. This is not just a Me Too. We have multiple rounds of BEAR. So BEAR 1 was a feasibility study. It looked at patients up to 6 years, even within BEAR 2, and now BEAR 3, we have 150 subjects. Enrollment has been completed. And that was on a label expansion, as well as comparing to multiple different types of grafts. So we've compared BEAR to hamstring, BTB, quadriceps, and now we're also having the Moon Group do a comparison directly within that institution, comparing BEAR and BTB with over 128 subjects enrolled. But I think one of the things that got me the most, and what I would apply BEAR to, is that in BEAR 2 trial, 86% of BEAR patients returned to some level of pivoting sports by 1 year, whereas in the comparative, only 70% of ACL reconstruction patients. So that's a big difference. And we're talking about MARC scores that are fairly significant between their baselines and getting them back to where they need to be. But even more so, if you're looking at the IKDC scores, patients at 6 months with BEAR have much higher likelihood of hitting a normal IKDC score than patients with ACL reconstruction. So for the patients who are not, who need to get back to their normal day-to-day knee and can't be tolerating any knee discomfort, it allows them to get back to that normal day-to-day, not necessarily getting back to sport faster, but then back to the normal day-to-day knee function faster than with ACL reconstruction. And we're going to get into this a little bit more detail. Dr. Kiapour is the expert on imaging the ACL, but we've shown this on numerous studies looking at ACL, MRI throughout the healing process, and comparing the slides, and even on looking at the slides themselves, taking a specimen and animal studies, 8 weeks, the entire implant has been replaced with native cells, new collagen, and blood vessels. I'm going to briefly talk about patient selection. Really, I think the original thought process was, oh, this is children's hospital, so this is for kids. But in reality, the studies were done in skeletal mature patients. And so I applied this implant to mostly adults. It can be done for kids. So when you're looking at BEAR usage, about 30% are under the age of 18, 26% over the age of 40, and 43% are in the age 19 to 39. And when you're looking at tear types, the majority are proximal, mid-substance 16%, but you'll see that with the usage and the commercial usage, that actually has gone down into the type 2s and 3s. So this is my personal experience of 42 patients with 12 months of follow-up. So on average, again, the youngest was 15 years old, not trying to push it into the pediatric population. The oldest was 60 years old with an average of 36, about 50-50 female to male. Originally, the first BEAR studies were looking at injury to surgery dates of 6 weeks. And so initially it was really trying to accomplish that. But as we've had more experience with that, we've found that it does not need to be so time limited. And I've had cases now in this study of 110 days. I recently did one that was 120 days. There have been ones that have been even farther out with anecdotal evidence. But you don't necessarily need to follow that 6-week parameter. I think the longer you wait, the higher risk that the ACL may resorb, and you have a harder time freeing it up. It could scar down. You have a harder time freeing it up, or resorb, and you have a harder time passing sutures. Tear classification, again, a lot higher rates of type 2s and type 3s, which we would never consider a repair option in these patients. But as long as you can get suture into that stump to redirect it in the right position, the BEAR will be a good option for these patients. And these are all high-level athletes. Most of these patients are recreational. We have a few high-level, but they're a variety of sports: skiing, soccer, volleyball, trampoline, and then a handful of 1-2% of football and other sports. There, as in any time you do surgery, nothing's ever 100%. There have been complications. Fortunately, they're no different than the complications you may see with ACL. So, when you use buttons, they can get IT band bursitis behind the button on the femur. So we had to remove 3 of those patients, of those 42 patients. One had an infection and one needed a manipulation. The infection was very delayed, up to 6 to 8 weeks in an immunocompromised patient. So when you're looking at patients, how has it been used? This is incredible. Over 5,000 patients have been treated with the BEAR implant since 2021. We have almost 500 surgeons through over 418 institutions in almost every state. Majority of these have been through the proximal type tears, but we've also been able to address mid-substance tears, and I think it's an excellent adjunct for partial tears where they may have some instability, either on a drawer or a lockman, and you want to go in and repair them. Maybe they have a meniscus tear as well. So you're repairing the meniscus and you want to supplement the ACL. You don't have to take the whole thing down, do a reconstruction. Again, looking at this fairly diverse group of ages, between 31% under age 18, 14 for the young patient, 30% for 26 to 39, and 25% over the age of 40. Again, this is a bridge registry. These are patients that are coming in, trying to monitor these patients. And so they're undergoing all different types of surgical techniques, various different types of physical therapy regimens. But in the majority of these patients are proximal type tears with a handful of mid-substance tears, mostly female and middle-aged.
So we are going to look at how we can leverage MRI to assess healing of the ACL after the BEAR procedure. In particular, we're going to talk about some of the technical requirements of acquiring high-quality MRI images for both qualitative and quantitative analysis. Also look at some of the important features distinguishing BEAR from an intact ACL and ACL reconstruction, and how we can use those features to track healing trajectory of a BEAR ACL, as well as to better make an informed decision on whether we need to do additional interventions such as revision ACLR. So there are 2 different types of MRI analysis. The most common one is qualitative, where we are using common clinical sequences to assess overall morphology of the ACL, as well as surrounding tissue structures. On the other hand, we can use some of the more detailed or quantitative sequences to further evaluate the structural properties of the healing tissue, in particular its mechanical strength, so we can predict that either using signal intensity or relaxometry. So for qualitative assessment, we typically use clinical sequences. These include proton density weighted, which we see on the left, as well as T2. These have good contrast to give us good view of all the different tissue structures, including fluid in the joint, so we can better understand the state of the tissue, as well as if there are any additional surgeries, if there are any additional injuries, and if there are kind of like any fluid accumulation in the joint. For quantitative or QMRI assessment, we will use signal intensity-based sequences such as KISS to give us an reading of the normalized signal intensity, which we can use it as a surrogate for tissue structural properties. Or we can use T2 mapping techniques to get a better sense of relaxometry properties, which is also a surrogate for tissue chemical composition and structural properties. But the signal intensity based have better anatomical, basically resolution. They are typically faster and more compatible with clinical settings, and relaxometry techniques are typically used in a research setting. So to do basically a good qualitative assessment, we need both of the PD and T2 sequences so we can see all different tissues and structures in the joint. We definitely need sagittal cuts, but if we do high resolution image acquisition, we can also use them to reconstruct coronal and axial views without the need to do additional coronal and axial imaging. And we definitely need to have a less than 1 millimeter slice thickness so we make sure that we can basically investigate through the whole thickness of the ACL. For quantitative signal intensity based assessment, we either use a KISS sequence, which is for Siemens, and equivalent of it for GE is Fiesta C, and BFFE for Philips. And we definitely need to find resolutions of voxel sizes less than 0.5. Similar to qualitative, we want to have a small slice thickness so we won't miss anything as we are surveying through the thickness of the ACL. And also the other parameters should also set to be standard so we can compare between different magnets and different patients. So here is an overall view of how BEAR ACL may look different from a native ACL as well as a reconstructed ACL. So for both ACL reconstruction as well as BEAR, they're going to look much differently across different time points, especially within the first 2 years as the tissue is basically maturing up within the first 2 years. But overall, they look slightly larger than a native ACL, in particular at the earlier time points. And for BEAR in particular, we see a lot of basically scar tissue around the edges of the ACL. So the edges of the ACL is not that well defined compared to ACL reconstruction, where we are kind of like seeing that tendon graft, which is very well defined, such as a straight band. But if you give it enough time, these scar tissues will get resorbed, so the ACL shrinks, and it becomes very well defined with more of these dark directional fibers. So here's an example of longitudinal changes in BEAR that we expect to see within the first 6 years. So pre-op, a scan shows that we have a mid-substance tear. Here's the tibial stump, here's the femoral stump. At early time point, we see a lot of scar tissues around the ACL, and in the middle, we see some directional dark fibers, which by the passage of the time within the first 2 years, we see that the scar tissue is getting absorbed, and we see more proportions of these dark tissues connecting the femur to the tibia. So the most important factor is that we have continuous connection between femur and tibia. And then the secondary factors is what percentage of this kind of like fibers are dark directional fibers, which we expect it to become higher as the time goes by within the first 2 years. When we look at ACLR, we don't deal that much with the scar tissue, so the ACL boundaries are well defined even at early time points, but we see that the proportions of dark fibers also follow the same trend as BEAR, where we see at 6 months we have less of those dark fibers. By 2 years, we see more of those in the basically reconstructed grafts. So one specific feature of the BEAR procedure is that the ACL is going to heal insertion to insertion regardless of the tunnel position. So this is because we are connecting the two stumps, and the stumps are connected to their bony footprint. So here we are looking at an example where the femoral insertion is drilled very close to the femoral tunnel is drilled very close to the original femoral insertion. So here we start from the tibial stump, and the tibial tunnel goes up all the way towards the femur. And depending on the location of the femoral tunnel, we may end up having a simple versus a complex, basically footprint. So here we are seeing that the femoral tunnel is very close to the footprint of the basically ACL attachment on the femur, and basically the insertion at the end is going to be very similar to what we had in a contralateral intact ACL. Whereas in this example, we have the femoral tunnel much more anterior to the insertion site. So a bundle of these kind of like tibial stump fibers are going to go and heal to the femoral tunnel, and the remaining of them are going to bridge to the femoral stump. So we have this complex morphology where it kind of like branches out. A portion of them goes to the femoral tunnel. The rest of them get attached to the femoral insertion. So regardless of tunnel position, since we have insertion to insertion healing, the ACL repaired with BEAR procedure is going to maintain the sagittal alignment of the tissue. So here we are looking at the BEAR knee, and here we are looking at the contralateral native ACL. If I outline the ACL and establish the longitudinal axis, I see that vertically they maintain the same alignment. So we have shown in the studies that while BEAR maintains the sagittal elevation angle, the ACLR is much more vertical and is directly basically dependent on the position of the tunnel. So all of those considerations for anatomic tunnel positions comes into play, whereas for BEAR, it's less of an issue. So it's going to heal insertion to insertion. And we know that the sagittal elevation has a direct impact on joint biomechanics. So for the next few slides, we are going to look kind of like in detail what will happen to the tibial stump over time and how the ACL remodels after the BEAR procedure. So for all of these on the left, I have the preoperative MRI where we can clearly see the tibial stump. And on the right, we have sequential MRIs at 3 months, 6 months, 12, and 24 months, so within the first 2 years. So at 3 months, we see that the tibial stump can still be identified. It's not fully integrated, but we start to see that scar tissue is bridging the gap from the tibia all the way to femur. And again, depending on patients and time points, we are going to sometimes, even at early time points, see some of these dark directional fibers. So for some of the patients, it takes 6 to 9 months to see some of these. But for this specific patients, we were able to see some directional dark fibers. So if we go to 6 months, we are still able to see traces of the tibial stump. And then we see that more of that scar tissue is maturing into directional high quality fiber. So we see high quality connection from the femoral insertion to the tibial insertion. Going to 12 months, the femoral stump is fully integrated into the repaired ACL, so we cannot isolate those fibers anymore. And we see, again, as expected, more proportions of the fibers are becoming mature and dark, connecting the femur to the tibia. And by 24 months, the ACL looks pretty good. Again, I would like to reiterate that this is highly variable at different time points and between the patients. So this is something that we would like to see on average, but there are some patients which have a slow healing response. So we have done large animal studies showing that the ACL size, in this case volume, but it could be cross-sectional area as well, directly correlates with experimentally measured strengths of the ACL, with larger ACL being stronger. We have also measured signal intensity, showing that the darker the ACLs are, so the signal intensity is lower, the ACLs are stronger. So if we combine these two into a model, we can predict the strength of the ACL from its signal intensity as well as size. And we have translated that model into humans. So when we apply it to human subjects, here we are looking at changes in average cross-sectional area within the first 2 years. So the dotted line is the average for normal intact ACLs. The shaded area is 95% confidence interval. We see that while both BEAR and ACLR are shrinking over the first 2 years, ACLR remains significantly larger, whereas BEAR becomes much more comparable to intact, in particular after the first year. With regards to signal intensity, both of them follow the same trend. Both of them stay highly unorganized with high signal intensity values, and sometimes in between 12 to 24 months on average, they hit that threshold of normal value. So they mature up to the normal levels. Again, this is on average. It's not going to be the same for all the patients. So here we're seeing an example of this is the average signal intensity for BEAR, which that transition happened typically between 12 to 24 months. But we have had cases where that took much longer to get to the normal level. Some cases even never get to the normal level, whereas some cases had a much more rapid response to healing and they matured up much faster before 12 months. This highlights the importance of personalized post-operative rehab, where we are using a combination of clinical function and MRI to decide when is a good time for patient to return to a sports and modify post-return to a sports activity levels to minimize the revision risk. So we have also measured the cross-sectional area across the whole length of the ACL. So 0 on the horizontal axis shows the tibial attachment, 100% is femoral attachment. And what we are looking at here is how the cross-sectional area changes across the whole length of the grafts in red, as well as blue is for BEAR and the dark is for native ACL. We see that the grafts are significantly larger throughout, whereas BEARs have larger cross-sectional area, mainly in the mid-substance when the repair happened, and we have majority of the scar tissue. But if you give it enough time from 6 months all the way to 24 months, we see that BEAR becomes very close to the profile of the intact ACL, whereas ACL reconstruction remains significantly larger. This shows that the BEAR can not only maintain the sagittal elevation, but also can replicate the complex morphology of the ACL throughout its length. So when we look at the early qMRI assessment of ACL strengths, we were able to predict the patient recovery in functional outcomes. So we saw that patients with graded predicted ACL strengths from qMRI at 6 months, they had the greater improvement in their single hop performance from 6 months to 24 months. Again, reiterating that these qMRI measures can help us with tuning in the post-op rehab. And we have also shown that in BEAR population, the qMRI metric measured early on is the only post-op predictor of risk of revision. None of the common clinical or functional outcomes were able to predict the risk of revision, with every 100 Newton increase in failure rate reducing the risk of revision by 34%. This is measured at 6 months, and the revision was tracked all the way to 2 years. So one of the challenges is that when we look at these MRIs sequentially, these patterns of tissue distribution is very complex. So one way to approach this, to simplify it, is create a projection such as X-ray of all of these voxels into one 2D view, and then further simplify them, dichotomize them into good and bad. So the gray ones are the good quality voxels where the signal intensity is at the same level or better than intact ACL, and the white ones are low quality ACLs. So looking at this approach, we can easily track how the ACL heals from 6 months to 24 months. We see at 6 months, we have a lot of low quality tissues spread out across the ACL. By 24 months, we see the majority of the ACL on average is good quality. And when you look at this across BEAR versus ACLR and intact ACL, we see that the BEAR at 24 months is very compatible to intact ACL. Again, showing that the BEAR is able to restore structural properties to the intact levels. So can we further use this clinically to help making decision whether we need to do additional intervention or not? So these are patients which had some sort of clinical symptoms or functional deficits such as instability. And what we did was we did an MRI at 6 months at the time of symptoms, and we repeated that MRI at 12 months, and we wanted to see if the patient needs to be revised or not. So when we look at these MRIs without doing any quantitative assessment, it's very hard to make that decision. But when we create these continuity maps, we see that the ACL doesn't have that much good quality tissue. At least these good quality tissues are not bridging from tibia to femur. It was at 6 months. When we give it 6 months, it didn't change. So the ultimate decision, considering all of the clinical and functional deficits, was to do a revision surgery. Another case was, again, the patient was symptomatic at 6 months. We repeated the MRI at 12 months. We saw at 6 months the tissue was not good, but there was a significant improvement. And we saw that the patient was on a path to recovery. So the decision for revision was to wait for now. So again, it is important to keep this in mind. These decisions are not made based on solely on MRI. MRI is some additional piece which can supplement your clinical and functional observations. Here are some cases where the decision without looking at MRI was to revise the ACL, but after analyzing the MRI, the decision was to wait, and they ultimately didn't decide to revise the patient. So we see that a 6 months patient has some symptoms. The ACL was kind of okay, but we had some huge chunks of low quality tissues. When we give it time, by 12 months, we saw that it got better. Still, it had some kind of like areas of concerns for discontinuity at the mid substance here. But ultimately, the patient recovered and didn't have major, symptoms. This was another case where at 6 months, the tissue quality was low. This case ended up having a revision ACL because the patient continued to have their symptoms by 9 months, although there was some improvements, but we see that this area, although we have some continuity here, but it was considered as a partial tear, and they ended up doing the revision. And this is an example where the patient was on the right trajectory path. From 6 months, it improved a lot by 12 months, but then they had a secondary injury, and by 24 months, at the time of doing meniscal repair, the patient needed to have a revision surgery. We see that the whole integration into femoral stump has failed. So the workflow in our institute to assess BEAR cases is that we do all of the batteries of functional and clinical assessments, and then we supplement it with longitudinal MRIs, where at each time point, we compare the patients to the rest of the population to see where do they stand with regard to average, and also track patients' recovery in terms of QMRI metrics to see if it's getting better or if it has plateaued or it's getting worse. And based on the combination of these data, we make a decision on the rehab as well as the need for revision. So for the rest of the presentations, I'm going to talk about some example cases where we have divided the patients into different categories based on the qualitative scoring of the ACL. So grades A and B on average are good ACLs, where we see good quality tissue for the most part and no concerns. Grade C, we see some significant concerns in terms of the signal being heterogeneous. We have areas of hypersignal intensity, as well as we see curved ACLs instead of a straight under tension ACL. And grade D are just no evidence of intact fibers. So here is an example of grade A. We see that the ACL across all time points looks really dark and well defined. It's in a straight line. It's not that common to see cases like this, in particular at early time points, but every once in a while it happens. So on the top, we see PD space. In the bottom, we see T2 scans. And both of these show that the ACL is very good quality, in particular when we get to 2 years. And all the way to 6 years, we didn't see any concerns with this patient. So an example of grade B, we see at early time points some areas of concern, as well as some intensity related to fluid across the knee joint. But when we get to 12 months and 24 months, the ACL looks good, and there are no issues with these patients from the MRI perspective, as well as clinical and functional performance. So grade C is a patient where we see an area of potential injury and derangement at 6 months, which goes away by 12 and 24 months. The ACL is not as good as the previous examples, but we can still see some of those features. We see a lot of scar tissues, but we start to see some directionality and some high quality fibers, which are getting better and better over time. And after 2 years, the ACL remains kind of like the same shape, and it has a lot of dark tissue. So the ACL is functional. It's not as good as the previous examples, but considering the clinical and functional, performance of the patients, there were no area of concerns, and the patient was fully functional. This is an example where the patient was on its path to recovery, but the patient had a partial tear, which didn't get better within 3 months. This is 9 months. This is 12 months. We see that the ACL is not getting reintegrated, so ended up needing to have a revision surgery. Here is the revised ACL with ACL reconstruction. Here we can clearly see the partial torn fibers, which didn't get reintegrated back into the ACL. And of course, patient had symptoms as well. This is another example where we had increased signal intensity as well as fibrosis, which didn't get resolved, and ultimately patient needed to have a revision surgery at the 14 months post-operatively. So this is an example where the patient was on proper healing track, had an injurious event, but when we repeated that MRI, it was partially got resolved and the patient's symptoms were better. So they decided not to pursue a revision. And by 6 years, we see that the ACL is fully functional, and we see all of these directional, kind of like straight fibers running from femur to tibia. So the last example is a specific type, which is rare, of kind of like re-injury, is where we have a lack of integration of the femoral stump to the tibial stump. So if you remember, the BEAR ACLs are healing from the tibial insertion. A bundle of them go into the femoral tunnel. A bundle of them heal back to the tibial stump. Depending on the size of the ACL and how big is this integration, sometimes you need to do an intervention to repair this, such as a partial tear. Sometimes the patient is doing fine. In this case, we see that there's a big bundle going into the tunnel, and that's under tension, and it's good quality tissue. It's only the femoral stump is connected from this posterior aspect of these fibers, and ultimately the patient didn't need any revision surgery. But if the ACL is very small, the knee looks unstable, this requires further intervention. So in some of these cases, you have good connection from femoral tunnel to tibial insertion, but the femoral stump is kind of like dangling and not connected, but the patient does fine. But some of the cases, that connection is not robust enough to stabilize the knee joint, and you need to do further intervention. Thank you very much. I hope this presentation was kind of like informative enough to show some of these features. Please feel free to reach out to us if you have any further questions with your MRI assessments. Thank you.
That was excellent, Dr. Kiapour. I just want to hit up on some other bridge registry highlights. So these are 79 patients who are 1 year after commercial launch, monitoring these patients. They have excellent mechanical examinations, 94% with firm endpoints and negative pivot shifts, and even grade 1 pivot shift, you're looking at 98.6%. And the patient-reported outcomes of 1 year, relatively normal IKDC scores 82.7 with a KOOS functioning score and KOOS pain scores. So these patients are doing very well. And even in this re-tear rate, I had a 2% re-tear rate in the cohort, 17-year-old non-contact pivot injury by playing basketball, and another 15-year-old playing hockey at 23 months. Both of those sports are high-risk sports. You would probably see that even with an ACL reconstruction, with an overall reoperation rate around 8%, contralateral tear 1%, a meniscus injury, and the manipulation under anesthesia and suture or button removal of 4. I wanted to go over a couple of my cases. So this is a patient here who is a 28-year-old soccer player and has kind of this mid-substance tear and relatively early on. Arthroscopically, we see this injury is a type 2 tear, one that I think had I not had BEAR in my hands, would have done a reconstruction. But this athlete was interested in doing the BEAR. We had an excellent remnant that we could put stitches through. And then we got an MRI at 9 months. And I'm interested in your opinion, Dr. Kiapour, but you see this, I mean, this is what, when I started seeing these MRIs of my own patients, you're seeing this linearity, you're seeing very low signal changes. What do you think, Dr. Kiapour?
I think this is a perfect post-operative MRI showing no kind of like issues or concerns.
Yeah. So this is, when you see these MRIs, I think they get you very excited about the potential for BEAR, and gives you that confidence that, even in, this is not just a paper that's done at Boston Children's. This can happen in your clinic, in your operating room, and in your physical therapy. This is a 38-year-old soccer player. Again, you can see this is a relatively acute MRI. Significant damage to the ACL. This is type 2, type 3 tear. And I said to the athlete, I said, look, I think I have enough remnant here to get there, but I always have a backup of reconstruction. At the time of arthroscopy, you can see there is a remnant here. Really ideally on the technique, I use a number 2 Vicryl, and I'll whip stitch that arthroscopically. I want to get at least 3 passes using a Bunnell type suture to get adequate fixation. In the type 1s, it's fairly easy. They're usually typically headed in the right direction. It's these type 2s and type 3s that can be flipped into the notch, so you need to mobilize them and move them forward. So again, you're looking at, and type 2 here as more type 3. And also had a ramp tear on the meniscus that we repaired. And then this is the 9-month MRI here. What do you think, Dr. Kiapour?
So as you can clearly see that even at 9 months, you can see those directional fibers. There are a lot of scar tissues, but you can see those dark fibers running from femur to tibia. I think this is on the right trajectory for complete healing.
Yeah, and I generally let them, at 9 months with an MRI like this, I let them start to engage back into high-risk ACL sports. There's another case here. This is EL, the 37-year-old soccer player, clear type 1 type tear. And you can see here that his tear already has started some healing. And in this case, I think this is a very straightforward, this is a great initial BEAR case because you'll really get comfortable passing your sutures in the stump. And clearly type 1. And this is a 9-month MRI. Dr. Kiapour, what do you think?
I think there is no major concerns. I can see a line where the bundle going through the tunnel versus the femoral stump may have some integration issues, but I think considering this early time point, that should be no issues if there are no clinical symptoms.
Yeah, this athlete has still had some strength deficits at this point. So we continued working on strengthening, but I was very satisfied with this MRI. I didn't think we needed to do another one. And so here we have a 43-year-old judge skiing. This is a type 2 type tear. You can see even the remnant of the femoral tear is pointing at right here. This is a type 3. Able to get a couple sutures through there. A 9-month MRI, not as satisfying, but what do you think, Dr. Kiapour?
So from this slice that we are looking at it, it's not as good as the previous ones, but I still can see functional, basically fibers. And considering the age of the patients, I think that should be good enough.
Yeah, he actually had some pain from this fibrous cyst right here.
Yeah.
And we injected some cortisone in his knee, and pain went away at the 9-month. And he continued to go back to skiing and working on other activities he likes to do. But again, this is a type of patient that, for him to be able to get back to normal life very quickly was the advantage of the BEAR for him, because he is a federal judge and needs to be sitting on the bench, and he just needs to be get a normal knee. And then he loves skiing, he loves playing soccer with his kids and basketball, but he's not an athlete where he's like, I can focus all this attention on my recovery. So, I mean, I think you've seen Dr. Kiapour's presentation on the MRIs. I'm sure you've had access to these studies that they've been produced through Boston Children's. And I've shown you all these MRIs on all these patients. But, you don't need to get an MRI on every single bearer. So I want to put this together, this kind of thought on when and when not to get an MRI. I mean, for me, there's a huge advantage in confirming ACL tissue. I'm curious, I wrote 6 months at the earliest, 9 months most common. Dr. Kiapour, when do you think if you had to choose one time to get an ACL, also understanding the clinical and logistical aspects of what that MRI will say in terms of return to sport, when do you think would be the best time to get an MRI if you were going to get one?
I think 9 months would be the best if it's going to be a single time point.
Yeah, that's what I thought. I certainly, Dr. Kiapour mentioned concerning physical exams. So in the earlier stages of BEAR, when there was some concern that maybe there's a little bit more play or the patient had an injury, that would certainly be another reason to get an MRI as well. Just a caveat, I don't try and stress the repair until at least 12 weeks. I definitely don't do it at 2 and 6 week mark. I think that there are some surgeons that are doing that, but I really want to give that time to heal, and I don't want to have an incident injury of doing like a vigorous Lockman and then having issues. So generally wait 12 weeks to test the repair, and then usually in my experience, the repair is very stout at that point. It may be the bridge, but it is very stout. And then I test again in 6 months, and then at 9 months they'll get an MRI if indicated, and we'll do an exam, and I give them their physical therapy report, and that's the decision making and return to sport. But also keep in mind that like MRIs I showed were just community MRIs. I have no control over the protocol, and the MRIs that were performed in BEAR are this qualitative MRI, which are a very strict protocol and not available in most community radiology groups. They take a little bit longer, and they are not designed to be read by most community radiologists. They don't have that segmentation software and things like that. So you're not going to get the same MRI quality that you are, but really, for me, it's the alignment and the signal that helps me make that decision making in terms of how are the patients doing and are they ready to return to sport in a safe manner. But also, keep in mind, this is not me trying to tell you how to game the system, but there are a lot of other ways that you can get an MRI approved for a post-op MRI. Most of these patients have femoral tibial bone contusions, so you may want to make sure that those bone contusions have resolved. They may have meniscus repairs. You want to evaluate if the meniscus has repaired, as well as associated ligament sprains. So these are other opportunities. If you're getting feedback from insurance groups saying that they don't want to approve it, certainly if it's a huge out-of-pocket expense for patients, I tell them it's not that necessary, but it can be very valuable. In my experience, kind of giving that confidence to the patients. These patients are coming into a technique that is just heading off of the early adopter and becoming commonplace. And so I think it's helpful to give those patients that confidence that they made the right decision, their ACL is stout, and they're ready to get back to sports. But let's not be fooling ourselves. MRIs are expensive, and in some patients, that may be a very big expense, particularly if they're crossing over a period, right? So if they had their surgery in 2024, and now they have to get an MRI in 2025, they're not going to have hit their out of pocket. So they may have to pay a significant amount of cash, and you have to discuss that with the patients. It will require some time out of your clinic to do prior authorization. And again, these are not the same qualitative MRIs that we've done in the previous studies, but they can be very valuable. Dr. Kiapour, anything else to add?
No, I think you mentioned all of the important points. Thank you.
So I just want to touch briefly on the PT protocol, because as in any orthopedic surgery, you can have a perfect surgery only to be messed up by a patient who doesn't do PT or a physical therapist that can be too aggressive or not aggressive enough, right? So you want to have the right PT protocol. And I think there are a fair amount of physical therapists that may not have seen a patient with BEAR, and they get very intimidated by it, and they tend to under-treat the patient. You have some physical therapists have never seen a BEAR, they don't even bother to look at it, and they're over-treating the patient. So whatever you do, I think you need to have that communication with the physical therapist. We provide the protocol to the patient, as I'm sure all the other surgeons on the call do, but reaching out to that physical therapist, connecting that physical therapist with one that's had a lot of experience with BEAR can be very helpful. And having early check-ins with the patient, whether that's via just email communication or in-person communication, just to make sure they're hitting those time points, particularly if they're doing therapy with an inexperienced physical therapist with the BEAR. But typically we're doing partial weight bearing. This is isolated ACL, partial weight bearing, 50% with crutches, They can start weaning as early as 4 weeks if they're hitting their normal gait criteria with range of motion. We use a brace. They're not allowed to bend the knee for 24 hours. And then we let them start opening up the brace and starting getting range of motion. We want them to do immediate post-op, working on their quadriceps, just basic muscle activation, but not a lot of strengthening. Formal PT, in my case, we start earlier on, but at the latest, starting 4 weeks post-op, and getting them with a physical therapist, and then working on PT, getting them to that 6 to 9 months, whatever cadence you find is best for that patient in terms of their strengthening and range of motion. But really, we don't want to be doing tremendous active range of motion or passive range of motion early on. So for the first 4 weeks, it's pretty much active and active assisted range of motion. And then depending on where they are, we may add in some more passive range of motion to get them going beyond that 90 degrees. In my experience, they are slightly about 1 or 2 weeks slower in terms of range of motion than an isolated ACL reconstruction, but they're about the same as a ACL meniscus. And if you're doing a bare meniscus, there's no difference that I've seen. So in summary, why BEAR? I think we've shown here on tonight's webinar that BEAR really restores the natural orientation alignment of ACL, both in a imaging standpoint. We've seen that it preserves proprioceptive fibers on a histological, and then also on the physical exam. There's restoring the patient's normal ACL mechanics. Also, it eliminates the graft harvest challenges that we see that added 10 to 20 minutes of prepping, getting the graft, prepping the graft, closing the graft harvest site, as well as the graft morbidity that patient will live with forever. And in the rare instances that we have to do revisions, as the patients get back to sport, high-risk ACL sport, they are going to injure their knee. We cannot remove the risk of ACL injury from the sports that our patients enjoy doing. And if they happen to unfortunately sustain that re-tear, what we found is that getting a revision after a BEAR have similar outcomes, patient-reported outcomes, as a primary ACL reconstruction. So almost like getting an extra ACL. We see less preoperative preparation and intraoperative considerations when you're doing this. As Dr. Kiapour says, you need to get it in the right zone, but you don't need to be as exact as when you're doing a reconstruction on the tunnel, because the ACL will find the right fibers and restore the normal mechanics. And this will have a positive impact on long-term joint health, as we've seen in terms of reducing post-traumatic osteoarthritis associated with ACL. So at this point, I'm going to end the webinar. I think we only have a few minutes left. If you want to hit any questions.
If there's any lingering questions from our audience, please put them now. But otherwise, we do not have any questions at this time. If you would subsequently like to email your questions, please do to meded@miachortho.com. But thank you to Dr. Faucett and Dr. Kiapour. I think we all learned a lot today. Appreciate you taking the time to help educate us all on the BEAR implant and its importance in ACL treatment. Thank you, everyone. Enjoy the rest of your night.